Zach Long, thebarbellphysio.com. Hey, Jeff. Got two questions that we're going to answer today for my Thursday thoughts. First, I'm going to answer Amy Pacula's question that she sent me on Twitter probably last week. She said, why are carries an important exercise to incorporate, and what is the best way to start doing them? So the big thing with carries, and I guess Amy asked this because a few weeks ago I did a hashtag 12 days of carry series where I did a different loaded carry variation every day of the week for 12 days leading up to Christmas. That was pretty popular. So loaded carries are all about integrity of the body, spinal integrity, shoulder integrity, and they can just be a great exercise to start somebody with a low level loaded option. Tends to be pretty non-threatening to the nervous system. So a lot of times if we're talking in the rehab world, somebody might get really freaked out if I was to ask them to do deadlifts to try to get some low back strengthening, or if I ask them to do some sort of kettlebell movement like deadlifts, goblet squats, it's going to freak them out. But I can get a pretty good load stimulus through the lumbar spine cord using different carrying variations that's not going to really freak them out quite as much because they're just walking, holding a little bit of a weight. It's also really cool. A lot of times when I find somebody that has like a lumbar side glide, and I've done my McKenzie type movements to try to correct that, and I'm not really getting it to stick. I found a few times that doing a unilateral carry on one side will kind of give them a little motor control input that'll correct that shift away. Also, I really, really love loaded carries when it comes to the shoulder. I like doing overhead carries, bottoms up carries where I have my elbow at about the same height as my shoulder, the bottom of it up. That creates a lot of stability to bands. Front rack carries. So basically they're just all about integrity, stability of the entire body, and they're a good segue into some different athletic maneuvers both in the clinic and for athletes. For me personally in my training, they're just a great way to kind of kick your ass in a few minutes. They don't they don't wreck your body, but they definitely give you a good muscle workout. So some things like sled carries, you can do sled carries, or sled pushes, and they tend to be a tough exercise, but they don't leave you like really, really sore the next day. Loaded carries are the same way. They can be a really hard, really good stimulus for it without being something that's going to be taxing, create a lot of DOMS, delayed onset muscle soreness, things like that. Second question I have, Zach Duhamel asks me, hey, there's Zach. You're just in time, Zach. I'm about to answer your question. What's your thought process and favorite interventions for anterior hip pain with full depth squat? So I should have a pretty good article coming out on this here in a couple weeks when I actually get a little bit of time to sit down and write this out and take some videos and pictures. So I'm really excited about this. This is probably like my favorite thing to treat, favorite thing to work on, because that anterior hip pinch can come from a ton of different stuff. Usually I'm going to watch somebody squat. That's going to let me usually figure out the first place or two to start right away. But if I'm not looking at you, the first place I really want to look is somebody's ankles. If they have ankle dorsiflexion, that's restrictions, that's going to throw everything in the kinetic chain off and really impact somebody's squat. So that's number one place that I start. Pretty easy test for that, SFMA wise. I get somebody to put their big toe one hand width away from the wall. So if the edge of my screen's the wall, I'm going to get their hand there. If this is their big toe goes right there, foot flat on the ground, and I try to see if they can touch their knee to the wall. If that doesn't make sense to you, I've written on that on my website multiple times. Really quick screen for if they have ankle dorsiflexion limitations that could impact their squat. From there, very rarely do people have such a poor knee flexion range of motion that they can't hit a squat, so I don't usually bother with knee flexion. My next mobility thing that I'm going to look at is hip flexion, hip internal and external rotation. Really with that anterior hip pinch, what I see all the time is lack of hip internal rotation and lack of hip flexion. And if I'll do some different mobilization techniques to get that hip internal rotation fixed, that'll clear a lot of hip stuff up. So I really like to do a little lateral distraction of the hip using a band and then performing like a mobilization with movement to get that hip internal rotation restored. A lot of times you'd be surprised at how often just doing passive range of motion, hip internal rotation, can impact somebody's range of motion really, really fast. And nobody ever goes into hip internal rotation as far as their mobility works. So just simply going back and forth in hip internal rotation can provide huge effects that somebody will get up off the table and do a squat after you do that, and they'll just be shocked because they've spent months stretching the shit out of their hip external rotators. They don't have hip internal rotation, and just restoring a little bit of hip internal rotation will make you look like a genius when it comes to somebody's squat technique. I also really like 90-90 breathing, that PRI exercise. I'm not a big fan of PRI. I just don't get their concepts, but I love that 90-90 breathing for a lot of different conditions. One, I can use it to kind of get the pelvis set so that you can go into a little bit more hip internal rotation. It also is good for helping to reteach that neutral lumbar spine position if we're talking about motor control issues, which I'll discuss here in a second. But it can really impact somebody's hip internal rotation as well. I wrote a really good article on that, if that's something that you're interested in learning more on Dr. John Russin's blog. It's titled "The Truth About Squat Depth, Injury Prevention, and the Knees Out Cue," where basically I talk about how people have spent tons of time looking at hip external rotation, mobilizing the crap out of their hip external rotators. Nobody's addressing hip internal rotation, and we're kind of jacking some people's squats up and causing actually a couple injuries that I've seen in the clinic with some of my athletes, CrossFitters, Olympic weightlifters, from not addressing hip internal rotation and only addressing external rotation. The final thing I like to look at is core control. A lot of times these people will, Dr. John Russin. If you don't follow Dr. John Russin, you need to. He's a physical therapist, strength coach, awesome guy. He puts out some amazing content. Again, the name of that article was "The Truth About Squat Depth, Injury Prevention, and the Knees Out Cue." Finally, I like to go to motor control. You'll find a lot of times people who start even just a little bit overextended in their low back, which puts them in a little anterior pelvic tilt. So as they go down into the squat, they're basically going to reach that limit of hip flexion just due to being in that anterior pelvic tilt. So if somebody's dealing with that, I usually start with that 90-90 breathing again. You can find a video of that on my YouTube page. I've written about it a few times. That'll just help get people back to a little bit more neutral back position. And then we can go to some other things. Right now on Instagram and Facebook yesterday, I put out an exercise, Psoas March, where you're on your back, trying to keep your back flat. We got a little mini band around your feet, and you're bringing one of your legs up into deep hip flexion. And that's another drill that I really like with these motor control people, because you get them working deep into hip flexion while really working to keep a stable lumbar spine. And from there, if we can get those kind of baseline ground activities going well, and I get them unloaded, controlling their core and their pelvic positioning, then I'm going to go to standing, doing some squat variations. A lot of times before that, I'll actually go quadruped rocking as well, to get them really going in through a very similar squat pattern in a less loaded area. If I'm going to then try to transition them to actually squatting, my first squat variation that I'm going to go to is the goblet squat. Having a kettlebell or dumbbell or plate right in front of your chest helps offset the center of balance so that their gravity is a little anterior. It lets them sit back posteriorly a little bit, helps them keep a little bit more of a neutral spine and not feel like they have to be so overextended. That tends to be a really, really friendly way to start squatting for these people that get an anterior hip pinch. And then I might progress that to front squats, back squats as their control there gets better. That's what I got on that. Like I said, there will be a good article coming out hopefully really soon, probably after I get done with my SCS exam here in March, that should be pretty comprehensive on that topic. So I'm going to sign off here in a minute unless anybody has any other questions they'd like to talk about. All right, guys. Thank you for signing in. I'll be up on Periscope, and I'll have it up on my website and social medias here in a little while. Y'all have a great day.